And welcome everybody to the forum. We'll go ahead and get started at 6:05. Thank you so much for joining the Bay Area Breast Cancer Forum. And this is our first forum of 2022. And we have a great panel to talk about some of the updates from the San Antonio Breast Cancer Symposium, which was a hybrid meeting with both virtual and live participation, very odd, big empty rooms. And some of us were there and some of us participated virtually, but it all went very well. I also want to give a big thanks to Melody, who's on the screen and can wave at you. And she actually has organized our whole listserv, so everybody should be getting the emails and really coordinated things beautifully for this forum. We wouldn't really have the forum if it wasn't for Melody's commitment and using her volunteer time to help us with this really important educational event. So thanks very much, Melody. We're really grateful. So we're going to talk about San Antonio Breast Cancer Symposium today, and you heard us talking a little bit about it when you all came in, and some of the interesting areas. So there is a fair bit of controversy over some of the areas, and I think that they play a role in our thinking about treating patients in both early stage and late stage disease. You can see actually, if you look on your screen, that Melody has put a one of those things you can take a picture of, a QR code, which I think takes you to where the website is and the recordings are, so that people can listen to the recordings who aren't able to participate. What I would ask you to do is at the bottom of your screen, you can see a Q&A box, and that's where you should put your questions. It's really great because we answer most of them live, but just in case we can't get to one, we can also type in answers for them. I know that we got a couple of answers ahead of time, a couple of questions ahead of time. If you can put those questions even into the box, it would be great, because then everybody can see them, just in case they didn't see them on the email. So again, welcome everybody. I want to introduce our panelists. I'm Hope Rugo at the UCSF Comprehensive Cancer Center's Breast Oncology program, where I'm a breast medical oncologist. From the breast medical oncology side, I'm joined by Michelle Melisko, who is been a long-term faculty member and an active clinician and researcher in our program, and Laura Hubbert. Maybe you just want to wave. And Laura Hubbert is a senior breast oncology fellow who we very much hope will start on our faculty in July, and is an excellent clinician and also beginning a great career in clinical and translational research in breast cancer. From our surgery side, we have Michael Alvarado, who's been incredibly supportive, a breast cancer surgeon and also a little melanoma, who is really been a huge resource and sees many of our patients in our breast oncology program. We have a fabulous surgery program, as I think everybody knows. And then we have Kim Ellis, who's our senior breast surgery fellow. And actually, unlike medical oncology fellows, it's kind of a different situation because there's no formal surgery fellowship in terms of boarding. So actually already boarded like doctor and surgeon, but then they're doing specialty training, which isn't required in breast surgery, which is just such a fabulous thing, because we have an active fellowship program that Michael's very involved with. And that means that the doctors who are going out and doing breast cancer surgery are trained by the experts. And that's great. Also can develop their beginning of their research career. So this is really a great thing. Our next forum is tentatively on March 30th, and we'll let you know what the topic is as we go forward. So what we're going to do is start with Michelle Melisko is going to do a case. We're going to a presentation. We're going to go back and forth. So Michelle, why don't you introduce your topic and go ahead and start. You're on mute, I think.
So I'm going to go ahead and share my slides for this presentation. And I am going to start by the caveat that I am presenting the actual slides that were presented at the San Antonio breast meeting. And I'm hoping that I can kind of talk through them in a way that patients and the listeners can understand and appreciate. So I know that one of the questions that had come in had to do with, how and why is this disease so prevalent, and are there any lifestyle and other lifestyle changes that we can make, diet, exercise, alcohol, that could impact. I presume the person who sent the question was asking about the prevalence of breast cancer. But this study was a long-awaited study looking at an intervention that is sort of the intersection between what we would consider to be sort of a pharmacologic intervention, as well as sort of interplaying with lifestyle, that we know that things like obesity and high insulin levels and hyperinsulinemia could impact breast cancer recurrence. And so we were anxiously awaiting this clinical trial. It was conducted by the basically the NCI of Canada, so a cooperative group in Canada, and it randomized patients to receive metformin or placebo in a group of women with early stage breast cancer. And so the background for this study was that we believe that patients that are obese, overweight, or obese have worse breast cancer outcomes, and that insulin levels are higher in obese patients. And so the idea is that if we could impact insulin levels through an agent like metformin, that we may actually have favorably impact breast cancer outcomes. And so metformin was a good choice to study because it promotes weight loss and lowers insulin. There have also been some studies looking at patients that get a short course of metformin before surgery, and it appears that the exposure to metformin may reduce the proliferation rate, this thing called Ki-67, in breast cancer cells. And there was also some preclinical data that it could slow the growth of breast cancer. And so then basically then the other thing that was relevant to this was that metformin is an inexpensive drug that's widely available throughout the world. And so if it did have an impact, it's something that could be widely utilized across the world. And so the design of the MA32 trial, patients between ages 18 and 74 who had been diagnosed with an invasive cancer within 1 year were randomized. And these patients could not be diabetic. And so they had a sort of a fairly rigid cutoff for fasting blood sugar of less than 126. They also could not be heavy drinkers, and they couldn't have any significant cardiac or liver or kidney disease. And they did a number of things that they stratified for patients. They looked at patients that were both hormone receptor positive and negative. They were looking at patients that had both high BMIs of greater than 30 and less than 30. They also did include patients that were HER2/neu positive, as well as HER2/neu negative, although the bulk of the data was in HER2/neu negative populations. And they also considered whether patient had gotten chemotherapy or not. Patients received metformin at a dose of 850 milligrams twice a day for 5 years. And to give you some perspective, patients that are relatively newly diagnosed with diabetes, type 2 diabetes, will often start with metformin at a dose of about 500 milligrams twice a day, and then often escalate up to 1,000. So this would be a kind of dose that's sort of at the low to middle end of normal for someone who's just recently been diagnosed with type 2 diabetes. It was placebo controlled, so patients did not know which arm they were randomized to, although metformin is known to cause some diarrhea. So I personally had a number of patients on this study who were convinced that they weren't getting metformin because they had no change in their bowel movements. There were a number of other correlatives that were collected looking at fasting blood sugar levels, symptoms, and health-related quality of life. Just to give you an idea of the timeline, and I think this is really an interesting point just to see how long it takes to actually conduct these long, very large trials that involve, lifestyle changes or interventions in early stage breast cancer, where the time to events may come, relatively slowly. Enrollment started in 2010, and it completed about 3 years later in 2013. And then we needed to actually wait until 2021 to actually have enough events, meaning recurrences and deaths, to actually drive the analysis that we're going to talk about today. And so the punchline for this study was that the primary endpoint was invasive disease-free survival in the estrogen receptor positive and progesterone receptor positive population. And unfortunately, as you can see here on the right side of the curve, something we call Kaplan-Meier curves, the percentage of patients that were had experienced an invasive disease-free or an invasive recurrence, so the percentage of patients that were alive without an invasive disease recurrence, basically were overlapping. I mean, you can barely only at this point even see that there's a dotted line versus the solid line, so the dotted line being placebo. And this number here, the hazard ratio of 1.01, means that they were essentially equivalent. And over here on this side of the screen, you can see that, at this duration of follow-up, there were about 18% of patients in both arms that had had an event. The majority of them, 10%, being distant recurrence, some being local regional recurrences, and then some deaths from other cause, and then a number of other patients that had a new primary non-breast cancer. So unfortunately, this was actually a disappointing outcome, similar to the invasive disease-free survival endpoint. They also looked at overall survival, and there was, again, absolutely no difference in the survival in patients that received metformin for 5 years versus those that received a placebo. And they looked, and then they also did an analysis. I'm sorry, I went to the next slide. They had done an earlier analysis looking at estrogen receptor negative patients. And I should mention that that arm had previously been stopped early because they had found that it was also futile, that there was no benefit from the use of metformin in the hormone receptor negative population. So one thing that we wanted to stress was that, just because this was a negative study, it doesn't mean that metformin should not be used in patients that have diabetes, who have breast cancer. But it does tell us that, unfortunately, this intervention, which was intended to lower insulin levels and promote weight loss, did not actually impact breast cancer outcomes. And there was an exploratory analysis in the HER2 positive population, which was kind of convoluted, and we aren't going to talk about that today. So that was the summary of this trial, and it was unfortunately quite disappointing. But there are other lifestyle interventions ongoing, including a trial called the Be Well study, which we participated in at UCSF, which is a cooperative group trial that was looking at a weight loss intervention, a weight loss exercise intervention. And I imagine that it will probably be at least another 3 to 5 years before that study reads out. That study was a little bit focused. It may have different outcomes because the focus was exclusively in patients that had higher body mass index, whereas this trial included, all comers, including patients that were lean, that were not high body mass index. So I'll stop there and we can shift gears.
Well, so Michelle, I think that's really interesting. And I think the Be Well trial is focusing particularly on patients who have, higher body mass index, and maybe is better than even the way this trial was organized. But you mentioned it was disappointing. I actually would have been really surprised if it was a positive result. I sort of feel like, we need to select patients a little bit better, that metformin is a relatively weak agent. I wonder if there's going to be a better way to do this in the future, but funding for these studies can be quite difficult. What's your thoughts about the future for this?
Yeah, I mean, I definitely think that if this had focused on a population of patients at risk, instead of just stratifying by body mass index, but limiting to patients that were, overweight or obese, and then perhaps even including patients that had sort of some level of insulin resistance at baseline, and trying to see if you could reverse that insulin resistance, instead of excluding those patients, we might have seen a different outcome. Obviously, I think there's still so much work that needs to be done in terms of understanding the impact of these interventions on inflammatory markers and things like that. And I know there'll be many, many studies and other publications that will come out of this, in terms of, blood that's drawn and things that they've done, to understand the outcome better. But I do think it leads to an idea that for lifestyle interventions, it can't really be a one size fit all for working, that just telling everyone to exercise, even though I'm a huge proponent of exercise, exercise probably isn't going to help, some, patients with triple negative breast cancer who have a genetically driven, breast cancer. But it may be very, very important for someone, who's overweight, who has an invasive lobular cancer. We just have to, I think there's going to be biological subsets of breast cancer where different interventions, both lifestyle and pharmacologic, will be useful.
Yeah, I mean, one of the questions is whether or not another drug that causes a slight decrease in BMI like Ozempic might be possible. And one of the problems with those agents is they're very expensive.
Yeah.
And they actually do cause decrease in glucose. There's a company that's been working on an agent that definitely it has efficacy in breast cancer in mice. So it needs to be studied. And there's a plan for a trial looking at it with the PI3 kinase inhibitor alpelisib or Piqray, which increases glucose. And in particular, patients who have high insulin levels and glucose intolerance. I think one of the problems is when we study these agents in more resistant cancers, it may be harder to see effects. But that's a whole nother area of research, which I think is really interesting. And you're a big proponent of the good old fashioned and harder diet and exercise, as Kelly brings up in the Q&A section. And I think, that's sort of an argument for Be Well, and how we can really help people with that. Maybe one of the things we need to be pushing for in the future is to have insurance cover that in patients with breast cancer. I mean, if you could show that it improved outcome, you could really make a push for having that, exercise programs and an exercise counselor be a covered benefit,
Yeah, I mean, I think it's tremendously important and in the long run, a lot cheaper. As far as other, diet and lifestyle, I think one thing that there's also a lot of interest in patients asking about, intermittent fasting, not only before chemotherapy, but as a weight loss strategy. And, I have done more reading about it as of late. And I think there is, quite compelling information about the impact of intermittent fasting and, just in general in longevity and impact on inflammatory markers and things like that. So hopefully, those kind of things will also, there could be some funding to look at, but doing a large scale study and getting people to be compliant is incredibly difficult. As we know from the women's interventional nutrition study that, the goal of having women, eat a low fat diet, that very few people by the end of the, 3 to 5 years could maintain that. So it's costly. It's easier to take a pill than to change your life, but it's worth doing, trying.
Yeah, there's a program called the fasting mimicking diet from Walter Longo. It's always, I think it's worthwhile reading what they have on their website. The diet you buy, the Prolon diet, costs money. So it's always unclear to me if it's worth it. But that fasting mimicking diet has been associated with weight loss. And in mice, again, they had better outcome with metastatic breast cancer. So we actually applied for 2 different grants to do that multi-center, neither of which got funded. And so you can see that it's a pretty tough path to go. And then as you mentioned, that intermittent fasting, there's also some programs available for that as well. I like this the fasting mimicking diet type idea. It's kind of cool, but who knows? I mean, the idea is that you lower insulin. Yeah, go ahead, Laura.
I was going to add, actually, yesterday in the New York Times, there was a big article. It was a UCSF cardiology study that showed that intermittent fasting maybe wasn't as promising as originally thought. They enrolled over 1,000 patients. And they thought that the weight loss was less than they would have expected and maybe more muscle mass. But the caveat to that study was it was only a 3-month follow-up. And they said maybe the benefits are more metabolic in long-term health. We should look at least a year of intermittent fasting, but kind of interesting hot topic. It literally published yesterday.
Yeah, it is really hot especially because the intermittent fasting versus fasting mimicking diet really has different effects on insulin. Nobody's been really measuring that routinely. So I'm sure they did in that study, but interesting question, I think. Somebody asked, Kelly asked if the Be Well app is available yet. Michelle, did you mention that there would be an app?
No, I don't. I'm not aware of there being an app. I mean, I'll be honest that I haven't attended the investigator calls as of late. I do know that we've completed accrual. The follow-up is ongoing. I can follow up with Jennifer Ligabell and find out, but I didn't know. I think one of the challenges, the intervention for Be Well, it involved phone calls and a coach, and so I'm not sure how that's going to translate into an app. And if I wasn't even aware. So, Kelly may know more than I do about it, but I don't know if that's translated, if the phone call coaching is translated into an app, how applicable it is or what we'll learn. But I think that's also a really, again, a hot topic is all this sort of technology to promote patients to change lifestyle and monitor their diet or exercise or that kind of thing. And I know at a recent forum and past forums, we've had, Natalie Marshall come and talk. And I think there's definitely things that need to be done technologically to help promote people to kind of stick with their resolutions as well, because, even the best of us fall off the rails.
I don't,
Even
I
the
never
most
heard you
committed
say
of
that.
exercisers,
So
those who love
of
exercise.
our group, I don't know how Kim exercises, but Michael bikes all the time. Laura is a biker and everything else, runner, and Michelle is a big runner. So we have a big exercise group here on the, I'm a terrible exerciser, but I just do it intermittently. This is the problem. Swimming, you can't swim in the winter outside, it's freezing. So
You gotta heat your pool. You gotta heat the pool.
yeah. Yeah, my foot costs what, I don't know, several $1,000s a month, but actually you can, you can do other things. I've been jumping rope recently. So there's a lot of things you can do that, are little things, don't require much, just to get your heart rate up and do some things, walk up, take a big walk up a hill, things like that. So
I thought that Be Well.
Hill.
Yeah, there you go. I thought that Be Well app was already out, but it was for like arm mobility and things like that for patients who had surgery after breast cancer, but that might be something different.
it may be, and maybe it has a different name for it, but I think the Be Well trial itself was this coaching and exercise, et cetera. So, but without having to follow a specific diet. People are doing studies. One of our colleagues at Memorial is having one where you get these meals delivered to you. But, the problem with those kinds of studies is that you have to pay for meals to be delivered to you in real life. And that's, exactly a big issue. So, well, let's move on now to the surgery side of things. And Kim is going to talk to us about some of the topics about local regional treatment.
Great, thank you, Hope. So I'm going to go over 3 updates that we learned about watching. Didn't get to go to San Antonio this year, but talking about local regional treatment and de-escalation, meaning doing less with breast surgery and local breast therapies. So the first study we're going to talk about is avoidance of radiotherapy for low risk early breast cancer using the Lumina trial criteria and accounting for endocrine therapy adherence. So we're looking at, can we omit radiation therapy in which patients? So the study followed a single group of patients in Canada. Their thought was that they can use clinical factors to identify low risk patients. And then the trial evaluated the risk of in-breast recurrence after breast conservation therapy, meaning lumpectomy or partial mastectomy, and sentinel lymph node negative women. So the women were over 55 and they had to submit like a journal of how often and if they took their endocrine therapy. And then all of these cancers that these women had were luminal A subtype, being hormone positive, HER2 negative, and had a low proliferation rate, or the Ki-67 that Dr. Melisko mentioned earlier. They had to be small tumors, not lobular cancer, so they had to be ductal cancer. They couldn't be high grade, and then no lymphovascular invasion. Next, so as we know, adjuvant radiotherapy kind of goes hand in hand with lumpectomy. However, in specifically low risk disease, the benefit of radiation can be minimal. So randomized trials have showed the feasibility of radiation therapy or of omitting it in subgroups, but based only on clinical pathologic variables only, so like size. There are 5 trials that are ongoing using molecular data, meaning the biomarkers that we just talked about, to refine who we can really omit radiation on. So this analysis reported the treatment outcomes of low risk, ER positive, early stage breast cancer treated with adjuvant radiation or non-radiation throughout multiple hospital systems. It had to be obviously the low risk population that we talked about, and then they analyzed the patients again, trying to see who took and who didn't take their hormone therapy and how that affected the outcome as well. So as we talked about, these women were over 55. They could only have a single tumor in their breast, hormone positive, HER2 negative. Margins had to be greater than 2 millimeters after surgery. And again, low proliferation, very slower growing. And they had to agree to start hormone therapy. We have 5-year data. We followed these patients for 5 years, and again, got them from electronic medical records. There was 110 patients met this inclusion criteria. 82 of them got external beam radiation, 28 of them did not. And then the endocrine therapy adherence was available for almost 100 of these patients. And then patients who completed 5 years of endocrine therapy or discontinued because they had a recurrence or death were categorized as the people who actually took endocrine therapy or endocrine therapy adherent patients, and those who discontinued for any other reason were deemed non-adherent. So as we see here, the two groups are not exactly identical. The age of the people that didn't get radiation were a little bit older, but as you can see here, all the tumors were ductal, small, and slow growing. This graph we'll talk about it with, I'm more of a numbers gal myself, but this graph will show us what we talk about on the next slide, which is the median duration of endocrine adherence was like the full 5 years that they wanted them to take. And if they didn't take the endocrine therapy, the average time that people took it was about 19 months or just shy of 2 years. And as we see here, the local control rate, so they didn't have any recurrence within the breast at 5 years, versus radiation therapy versus omission were 100%. They didn't have any recurrence with radiation alone. And then versus omission, they had 94% of patients go without a tumor recurrence. I think the interesting part about this is, if you adhere to both the endocrine therapy and radiation, you have 100% control rate at 5 years. However, if you omitted radiation and didn't take your hormone therapy, you had a 27% chance of, a 17% chance of in breast recurrence at 5 years. So in this new study, it showed that, very low risk breast cancer exhibited excellent local control with endocrine therapy alone, as long as they adhered to the treatment. Obviously, we need to await a much larger population to study this. But what was interesting about this is that endocrine therapy alone may be insufficient to control recurrence within the breast if you don't take it the full 5 years every day. And obviously, we need to, rather than chart check and look at these patients in the past, follow them over time from the very get-go will be helpful. So next, we're going to talk about safety of conservative surgery with accelerated partial breast re-radiation for isolated ipsilateral breast cancer recurrence, regardless of immunohistochemical subtype. So meaning, can we give someone re-radiation after with a in breast recurrence? So we know that I know we talked about 5 year, but over 10 years, the failure of breast conservation therapy, meaning lumpectomy and radiation with endocrine therapy, is about 5 to 10%. The standard of care has always been, if you have an in-breast recurrence, we go straight to mastectomy. So we don't have any solid data showing that we don't need to do a mastectomy at the second attempt. Can we try again with breast conservation therapy and re-radiate these patients? So obviously, when someone has a recurrence, that is a mixed bag of people. Is it true recurrence? Is it a new tumor? So close, with these patients need close clinical follow-up to detect this. So, and now that we have great imaging studies and very close follow-up, technically we can do a second lumpectomy. So who is that safe on is really the question that we're trying to answer. So the women that they included here are over 50 years old. They had to be greater than 4 years from their initial breast cancer treatment. It had to be localized, so it couldn't be a distant recurrence. It had to be an in-breast recurrence. It had to be a single tumor that was less than 2 centimeters. And they couldn't have had a bad reaction to the initial radiotherapy that they received. And then they had to have a breast volume, meaning the breast had to be amendable to another lumpectomy. They couldn't have too small of tissue. So as we see, most of these were, or all of these were ductal cancers. Some very few of the recurrences were DCIS, so they were mostly invasive. They were mostly hormone positive. And we can see that it was split between about how fast these tumors were growing. So all of the patients that they followed were treated with a second lumpectomy and accelerated partial breast radiation, meaning a shorter course and just to the tumor, localized to the tumor bed rather than the whole breast, including the lymph nodes. And the majority was our traditional radiation. There was a small subset that got intraoperative radiation, and then most of them used photons, which is, you know, getting into the weeds of radiation. But the median follow-up was just over 3 years. They had one patient come back with another in breast recurrence, and then 3 metastatic recurrences. And both were found to be of very aggressive subtypes. So we found that the 5-year regional control rate was over 80%, and metastasis-free was almost 85%, and overall survival, you know, up into the 90s at 93%. And the 2 deaths that occurred in this group were unrelated to the breast cancer. So in conclusion, we know that, you know, this is feasible to do a second lumpectomy, and it is safe to do re-radiation for patients. So this is a great conclusion that you don't have to go straight to mastectomy and save patients, you know, a big operation if they don't need it. So something that, you know, we always
Let me
like to
just
focus on.
break in
Yeah.
for a second
Yeah.
and ask you, one of the questions that came up was, what is considered a major radiation toxicity in that study?
Yeah,
Dr.
so
Alvarado.
yeah. So I think if you have severe skin problems with the radiation, also, you know, fancy word to like, if you get these kind of very prominent, what you might call spider vein looking things on the skin, if you had a problem with the incision after the radiation, maybe it didn't heal very good, or if you had severe hardening of the breast after the radiation, so the scar tissue, for example. So those would be the kind of the most common kind of very significant issues with radiation. So the skin changes, you know, significant problems with the skin in terms of not just getting a little bit pink, but maybe blistering or problems with the wound healing. And then also these kind of telangiectasias, these the spider vein things that show up.
Telangiectasias.
I know, sorry. And those types of things. So that would be what would be kind of referred to. The good news is that in today's treatment of breast cancer, those are very uncommon because they've gotten so good with the radiation. So I think it would be unlikely to have that these days, which is great.
I think that, you know, we saw an unusual radiation toxicity, a delayed toxicity, which we definitely saw in the distant past, but a patient had a mastectomy and didn't have a lot of tissue, which I think, you know, when you've had no reconstruction or mastectomy, you do get more tissue radiated, more normal tissue radiated. But this patient had radiation and then had several non-pathologic, so benign rib fractures in the radiation field.
Yeah,
So
that
this is-
also is definitely possible, unfortunately, as Dr. Rugo was saying, especially in the mastectomy patients. It tends to be less likely, but it's possible even in patients that have lumpectomy. So yeah, that would definitely be a contraindication to having radiation again.
Interesting. Okay, go ahead, Kim, sorry.
Right, and
Oh,
something
there was
that,
one other question. I'm so
Oh, yeah.
sorry. It says, what about the recent Danish study that showed better outcomes, less recurrence than endocrine therapy? I don't really totally understand the question.
Well, if it may be kind of the central theme of what Dr. Ellis was talking about, and this is something that comes up a lot, a question of, you know, yeah, it's great. This patient looks like we can omit the radiation, but the issue is that will work great if they can take the endocrine therapy. But as many people know on this call, and as Dr. Rugo, Dr. Melisko, and Dr. Hubbert know as well, that it's really, really difficult to take the endocrine therapy. So many women end up stopping the endocrine therapy and maybe that increases their risk of a recurrence. So then the question could be, and again, Dr. Rugo, we've talked about this before about trying to identify, and this gets really, really difficult, which patients, maybe over the age of 70 that could just have lumpectomy and radiation for local control with such a low risk of distant recurrence that maybe they don't have to take the hormone therapy, but it's such a difficult way of trying to figure out who those patients might be. I think that's just really, really hard. So I think, yes, I think radiation and surgery is very, very good for local control, but surgery and endocrine therapy is also very, very good local control. And I think it's just hard to know, what we could do in those patient populations.
That's great. Thank you. Kim, go ahead.
Right. So something that we, as we know, axillary or the armpit part of the operation can be pretty morbid and risky. So, we are in today's day and age are trying to do everything we can to decrease the amount of surgery that we do in the axilla. So this particular study is still ongoing, but we have a little bit of an update. So patient-reported outcomes for the Intergroup Central Mama study, or INSEMA, persistent impact of axillary surgery on arm and breast symptoms in early breast cancer. So the primary outcome of this study, they're taking this big group of patients and randomizing them twice, once to no sentinel lymph node biopsy and once to a sentinel lymph node biopsy. And then again, once they have the data from the sentinel lymph node biopsy, they're randomizing them again to completion axillary dissection. And so removing all of the lymph nodes in the armpit versus just keeping with the sentinel biopsy alone and seeing what happens. So the part of the study that is showing the outcomes of these patients in terms of cancer and things like that will be reported later. But what we're going to talk about today is a secondary objective of this, which is quality of life. How much impact does having no axillary surgery at all versus the full gamut, how much does that change someone's life? So this is a very large study. They have 5,000 patients, few of which dropped out. And then, like I said, first they were randomized. They had 1,000 patients randomized to no axillary surgery at all, over 4,000 randomized to having a sentinel lymph node biopsy, so a sampling of those lymph nodes. And then we see here all of those, the ones that had 1 to 3 positive lymph nodes were randomized again to completion axillary dissection versus sentinel lymph node alone. We know that if someone has their lymph nodes are chock full of cancer, that the standard of care is to still remove all of them. But there's this gray area of if there's a couple positive, but it's not all of them, what do we do then? Can we decrease the amount of surgery that we do on these people? So this is after the first randomization. So no sentinel lymph nodes taken versus what we think of as the normal sentinel lymph node biopsy or sampling of the lymph nodes. There was really no difference in global health status. So how do they feel on a day-to-day basis, physical functioning, emotional functioning. There was no difference between these two. Where we found a difference for these patients were breast symptoms. So breast swelling, breast pain, and arm symptoms were a little bit even more pronounced. So arm swelling, hand swelling, arm pain. These were really only statistically difference for the arm mostly. So we looked at the second randomization. So if we stick just to the sentinel lymph node versus completion axillary dissection, there were no difference in the breast symptoms between these folks. However, there was a meaningful difference in the arm symptoms, so arm swelling, which is fairly consistent with what we know. The more lymph nodes we take out, the more risk there is to arm swelling, and that is going to impact someone's life. So, continuing on, so we can think of this as kind of a graded fashion. Obviously, if we do no axillary surgery, interestingly, there's still some arm symptoms, even though we didn't touch the armpit. And then as we get more invasive, so a sentinel lymph node biopsy has more symptoms, and then an axillary dissection has even more symptoms, meaning arm swelling. And this is all patient reported. So the patients reported that they had these symptoms. So, who can we de-escalate on, and is this going to be safe? I think outcome-wise, this is still to be determined. However, in terms of patient outcomes, the less surgery we do, we're finding that it impacts patients less. So if we can do less, we should. So can we omit a full axillary dissection in these very few lymph node positive patients? And then can we omit radiation after lumpectomy on a set of patients that are endocrine therapy adherent? And can we decrease the use after mastectomy? And so changing, our scope and, really having a frank discussion about the patients and their goals moving forward, we can, lessen the amount of surgery that we do as we move on and find out more about who we can or can't do that for.
So that's interesting. Michael, is that something that you do now?
Which part? All of those?
No, like, so, we
Yeah.
were talking a little bit about the fact that in the neoadjuvant setting,
Yeah.
if people get chemotherapy first and they had positive nodes, so we knew they had disease in their axillary nodes and everything shrinks away, that here at UCSF, we tend to do a sentinel lymph node and sort of a quick exploration, and we don't try and do a full dissection in those patients.
Yeah.
And alternatively, if a patient gets therapy and neoadjuvant therapy and has a single node positive, we tend not to do a full dissection.
Yeah.
But that's not the standard nationally.
Yeah.
What are your thoughts on that?
Yes, so controversial discussions, as you know, and Dr. Ellis, obviously, we talk about this every week, and Dr. Melisko knows as well. We present these cases at Tumor Board every Monday and have these discussions. It's it's really, really difficult. I mean, I think as just with everything, just like the medical oncologists have realized over time, is that when it used to be, 15, 20 years ago, everybody got chemotherapy and then realized that, okay, not everybody benefits from it. I think that's kind of where we are in axillary surgery, that yes, of course, there are going to be some patients that need the complete removal of all the lymph nodes in the armpit, but the majority are being overtreated and have risks of these problems. And again, the hard part is trying to figure out who they are. Now, for the oncology patients and chemotherapy, we have these great genomic assays that help kind of determine who will benefit. We don't really have that for surgery patients, but we have trials that are ongoing, but we also have pretty good retrospective data for observations showing that women do very, very well without the big surgery of the armpit if they're getting radiation, and that there are so many trials that show how well radiation works for controlling microscopic disease. And I think the biggest issue is that it's not that our group is advocating that nobody should get axillary lymph node dissection, but there should be at least a conversation about risk benefit. What's this patient? So, if Mrs. Smith has a micrometastasis in one lymph node out of 3 after neoadjuvant therapy, that's obviously very, very different than Mrs. Jones that has a 2-centimeter metastasis in 1 out of 2 lymph nodes after neoadjuvant therapy. So I think it's just being able to have that discussion and think about the risks and benefits. And then the last thing I think that Dr. Ellis was also mentioning was just the whole concept of avoiding sentinel node biopsy. And I know Dr. Melisko and Dr. Rugo, we tend to drive you crazy with offering our patients no sentinel node biopsy for certain patients, because those are kind of guidelines or subtle recommendations from Society of Breast Surgery and the Society of Surgical Oncology, where if we feel that potentially the lymph node is not going to make any difference in changing therapy, then we offer to omit it. But again, this is taking a little bit of a leap of faith for some patients. I mean, there's always going to be kind of this gray area. so I think, having a clinical trial that might show when we truly can omit the sentinel node biopsy will make our oncology partners feel a lot better on Monday when we discuss these cases, I think. So it's moving in that direction. I think, precision medicine, as Dr. Shanahan had mentioned, I think in part of in the chat, so that, we're doing the best we can to do this. And it's hard to get other people to get on board with things that we feel pretty comfortable with. I mean, I think even in our oncology group, do a lot of things a little bit different than the rest of the country because we're forward thinkers and we have such a great oncology program. So yeah.
It's just being in the West, we're cow people. So the question, one of the things that people have been doing, Michael, is this lymph vessel microsurgery to try and reduce lymphedema. Could you just briefly mention that?
Yeah, so that's a great question. So as we were just talking, unfortunately, there are women that end up getting the big axillary lymph node surgery. And so the question is there anything that can be done surgically to try to prevent the lymphedema? And so there are a couple different surgical procedures that are done at the time of the dissection. These, one of them is called the lymph procedure, and we're trying to connect the lymphatics to draining veins to help decrease the pooling of fluid in the arm. At UCSF, because we do less axillary node dissections, I think we hadn't really embarked on having that program. But just recently, in the last 6 months, we hired a new plastics microvascular surgeon by the name of Dr. Rose, John Rose, who actually is very proficient in this lymph surgery. And so, and I think what's great is that it can be there for our own patients, but even more so, we can now be a center maybe for women that have had axillary surgery somewhere else and now can come here if they have moderate or mild lymphedema, and Dr. Rose can see them and potentially offer them a surgical procedure to try to reverse that. So it is definitely something that's becoming more prominent. The data looks pretty good. It's not a slam dunk, obviously, but there are at least some more options for women that unfortunately undergo this terrible, terrible thing of lymphedema.
Great, thank you. And I think, all of these things are really important. I mean, I remember when I was training that, in the 80s, the idea was, first of all, people had full dissections, but also the idea was you shouldn't ever do anything with your arm, like no exercise. And it turns out it's exactly the opposite. So research is incredibly important to try and help people. So we're going to go on and keep asking everybody in the panel different questions as we go along. But Laura Hubbard's going to start with a couple of presentations, and then we'll go to Michelle to talk about some of the new hormone agent that's being studied.
Great, let me just share my slides. Perfect. So the first study from San Antonio that I wanted to share today is about datopotamab deruxtecan, which is a mouthful. So the short name for that is Dato-DXd, in advanced or metastatic HER2 negative breast cancer. So this is a subset of results from the triple negative patients with triple negative disease. So by way of background, antibody drug conjugates are composed of a monoclonal antibody that's linked to a cytotoxic payload that basically allows the cytotoxic piece of it to be delivered more directly to malignant cells. So the way I think about that is it's sort of like chemo, but it is like chemo, but it's linked, the antibody allows the payload to be delivered a little bit more directly to the malignant cells. So this is a really exciting class of medications for breast cancer that we're studying at this point. Several approved, but several also under investigation. So Dato-DXd is one of these ADCs. And when we talk about antibody drug conjugates, you can vary 3 different pieces. You can vary the actual antibody, you can vary the linker, and then you can vary the payload or the cytotoxic piece that kills the cancer cells. So these are the different components of this particular antibody drug conjugate. So in this study, They enrolled patients with relapsed or refractory solid tumors, so multiple tumor types were included, but the data I'm going to show today is the triple negative cohort from these patients. The primary objectives, this was a phase 1b study, so safety and tolerability first and foremost, but also thinking down the line about what are the efficacy of these agents. So looking at some of the efficacy endpoints first, just because it's very interesting. So of the 44 patients that they enrolled in this study that had triple negative disease, the objective response rate, or how many people actually responded to the drug, was 34%, which is pretty exciting. So you can see in terms of the change from baseline, these are people where their disease got bigger, but you can see the majority of folks here, the disease shrunk. So it's really exciting. And then specifically looking at some of the patients had previously received a similar antibody drug conjugate. So excluding those patients and just looking at the patients who had not received a prior antibody drug conjugate, the response rate was even higher, so 52%. So pretty decent response rate. And one of the things that was really interesting was that the response seemed to be fairly durable, meaning that even looking many months out, many people still had a continued ongoing response, which was promising. And the median duration of response was not yet reached at the data cutoff, but the range was 2.7 to 7.4 plus months. And of course, they're still looking at the data as we speak, so we'll know that down the line. But in thinking of adverse events, the most common adverse event, as you can see, was nausea for this agent, and then stomatitis or mouth sores. And the dark blue here is grade 1 to 2, meaning it's less severe, and then the striped version is grade 3 or 4, which is much more severe. So the majority were the grade 1 or 2 events, and then a few more grade 3 or 4 stomatitis here. But most, there was less frequency of diarrhea or blood count abnormalities. And then importantly, several ADCs have been associated with something called interstitial lung disease, which can be pretty severe, and they did not see that in this cohort of patients. So the conclusions from this study were that in these heavily pretreated patients with advanced triple negative disease, Dato-DXd showed encouraging and durable efficacy. So among all of the patients with triple negative disease, the response rate was 34%, and then 52% in those who had not received a prior topo inhibitor-based ADC. And the safety profile was manageable, with nausea and mouth sores being the most frequent. So I think it's a really exciting new drug. The hormone receptor positive HER2 negative cohort is now fully enrolled. And so data is forthcoming. What I just showed you is all in triple negative disease, but that data will be presented too. And like I mentioned, this was a phase 1b study. So phase 2 and phase 3 studies looking more at efficacy are planned or have started. So we can look for that data in the next few years.
So that's a really nicely done and very nice summary. It's a really interesting agent and so fascinating that it causes mouth sores where none of the other ADCs really do. And it has not yet been associated with the inflammation of the lung called interstitial lung disease that's been seen with trastuzumab deruxtecan, or so-called Enhertu. One of the questions was, does this ADC have the same payload as the Enhertu? And yes, it does. They have actually all of their ADCs, of which they have 3, another one directed against HER3 that they're not clear. Right now, it's still not clear where they're going with it, but they all have a deruxtecan payload. And the hormone receptor positive trial will be opening here, I hope, in the not too distant future, and the triple negative trial is being planned and finalized. So that's one question. There was a ER positive. I think you answered the question about that, the hormone receptor positive cohort. Maybe we'll see it in ASCO. That would be, I think, the first meeting that it would be available at.
Hopefully.
Maybe ESMO BC. So ESMO breast cancer, which is a European Society of Medical Oncology meeting. But it is fascinating because if you think about sacituzumab govitecan, and which is called Trodelvy, that's approved for triple negative breast cancer, but we completed already a trial called TROPICS in hormone receptor positive disease. It's a topo 2 antibody, targeted antibody. So it is the only one that could have been given to these patients who had a prior topo inhibitor ADC. It's the only one that those patients had, that we saw responses in early trials. So the triple negative patients, it's approved and people can get it anywhere. For hormone receptor positive disease, the TROPICS trials completed accrual, and we're planning to see data at ASCO, the American Society of Clinical Oncology, which is beginning of June this year. So that's going to be a similar drug, right? And so that drug was, the way they studied it was patients received 2 to 5 lines of prior chemotherapy for metastatic disease, which means, 8 treatment and then change to another treatment would be 2 lines. So the way they're studying this one in this new trial called Tropion is in patients who've received 1 to 2 lines. So they're trying to look at a different group of patients like earlier. So the competition is pretty fierce, but I think that's a great thing because that means we're going to have more options for our patients in terms of treatment. And one of the things we really like to do is to take these drugs and move them into the early stage setting in patients who have higher risk disease, both after surgery, if you didn't get a great shrinkage to chemo given before surgery, or even before surgery to see if we could get better shrinkages. So there's a lot of potential applications for these new ADCs. Most of them don't cause complete hair loss, but they have unique side effects. Really interesting. Any other comments about this? Okay.
Perfect. I can talk about one more study and before we switch back to Dr. Melisko. So another study I wanted to share that I thought was really interesting at San Antonio was the Destiny Breast 03 subgroup analysis. So this is a study of trastuzumab deruxtecan, or TDXD, versus trastuzumab enstamancyne, TDM1, in patients with HER2-positive metastatic breast cancer. And so some of this data had already been presented, but they presented subgroups at San Antonio. But just by way of background, as many of you know, for HER2-positive metastatic breast cancer, typically in the first line, we're using a taxane chemotherapy plus trastuzumab and pertuzumab, or Herceptin and Perjeta. And then previously in the second line, TDM1 was used, and then the third line, TDXD, or tucatinib, trastuzumab, and capecitabine. And so the question in this study was really, should we compare those two, and should we, if we put those two head to head, which actually works better, and should we consider changing the order there? And so in Destiny Breast 03, it was a randomized phase 3 study that compared head-to-head TDXD versus TDM1. So 520 patients with unresectable or metastatic HER2-positive breast cancer that had previously been treated in the first line with trastuzumab and a taxane were randomized to receive either TDXD or TDM1 in a 1-to-1 fashion. And the primary endpoint was PFS, or progression-free survival. And then secondary endpoints were OS, or overall survival. And so looking at the primary endpoint was progression-free survival, and this data had previously been presented as well, but it was really exciting data that TDM1 here is in the gray, and that had been, like I said, the previous second-line therapy, and then TDXD had previously been after, but it showed that TDM1 had a progression-free survival of 6.8 months versus TDXD. They actually didn't reach the progression-free survival because people did much better. At 12 months, 34% of patients with TDM1 had a PFS percentage, 34.1% had a 12-month PFS rate versus 75.8% of TDXD. So I think this data was really amazing. You never really see curves that separate that much, showing that TDXD really was superior to TDM1 in these patients. And so at San Antonio, they looked at, is this true across subgroups? And so if we look at that specifically in patients that had hormone receptor positive or negative disease, if they'd had prior pertuzumab, if they had visceral disease, meaning disease in the liver and other visceral organs, number of prior lines of therapy, and then brain mets, is it still true that that difference persists? And you can see this dotted line, when you see these graphs, means they're equivalent. And then this basically, they're all way far to the left here, showing that across all subgroups, the same trend held true, that TDXD outperformed TDM1. And so looking specifically in patients with brain mets, so this trial allowed patients who had stable treated brain mets to be enrolled. It excluded people who had progressing brain mets or leptomeningeal disease. But among patients with brain mets, also TDXD outperformed TDM1 in patients with brain mets, and then again, in those without brain mets. So I think really encouraging here, as you can see, in patients with brain mets, TDM1 had a PFS of 3 months versus TDXD had a PFS of 15 months. So a 12-month difference there. In terms of side effects, the side effect profile is slightly different between these drugs, but you can see here neutropenia, for example, in TDXD had slightly higher rates of neutropenia, with 19.1 having grade 3 neutropenia, whereas TDM1 had slightly lower rates of neutropenia. In contrast, TDM1 had higher thrombocytopenia or low platelets. So some differences in the side effect profiles between the two drugs, but I think interesting to note. And so the conclusions from these studies that TDXD demonstrated consistent efficacy of benefit over TDM1 across all the subgroups that I showed you, and also showed particularly efficacy and reduction in brain mets, in the CNS lesions in patients with brain mets, which was really encouraging. And the safety profile, like I said, there were some differences, but relatively similar safety profile. And so these data supported that TDXD should really become the standard of care for second-line HER2-positive metastatic breast cancer. So thinking about, rather than having TDM1 in the second line, based on this data, that TDXD should really be our new second line for HER2-positive metastatic breast cancer.
That was great, really interesting. So Michelle, I wanted to get your take on this presentation.
Yeah, I mean, it's obviously fantastic data. It's some of the best in terms of, the long-term stability of disease that we've seen. And, I think it's going to change practice. I think, obviously, from my perspective, I'm so excited to see the data on the brain mets, and the idea and the concept that the antibody drug conjugates, that these drugs are too big to cross the blood-brain barrier. I think that we're questioning that in patients that have had brain mets, if they've had recent radiation, there may be some breakdown of the blood-brain barrier, or an agent like this that has such a high payload, and that the payload, the drug that's actually getting in whatever amount that can get into the central nervous system, has been shown, these topoisomerase inhibitors may have some activity in CNS disease, makes it more interesting. We've known for a long time that taxanes and other microtubule inhibitors may not be the best agents to use to treat brain mets. So this drug, I think, has two advantages. It has more, payload, more drugs, and so more drug that might be able to get in. So I'm excited about that, particularly because, HER2 positive breast cancers have a greater predisposition to developing brain mets. I think, understanding the side effect profile and, who this is going to be right for, it's going to be hard to not want to give this to a patient second line. Although, I have seen some hair loss with this, and whereas I don't see any with TDM1. So I think, there may be still a few patients where, TDM1, may still be a reasonable choice for second line disease. And of course, now we'll be using, more TDM. We already do use more TDM1 in the adjuvant setting in patients that have not, those high risk patients that didn't achieve a pathologic complete response after neoadjuvant chemotherapy. So it'll be interesting. I mean, none of the patients in this trial likely received TDM1 in the adjuvant setting. So I think the data would be even more impressive, and TDXD will want to reach for that in those patients who have already been exposed to Kadcyla in the adjuvant setting.
That's interesting. I mean, so what do you think? There is a risk from TDXD of this pneumonitis, although they didn't see they did see grade 1 and 2, and some people discontinued. Not too many though. I mean, just really not. It was no
Yeah.
people died from that, and we hate people to die from side effects that aren't cancer.
Yeah,
I mean,
and
really
of course,
bad.
and you know, one thing that I think is going to be very, you know, in the trials, because we saw so much of the, you know, the concern about the interstitial lung disease early, and those investigators that have been really involved in the drug development, you know, are so paranoid about this, that we monitor people really, really closely. And I think one thing that may be kind of scary in, you know, when sort of this is let loose and people are using it much more freely, is that if patients are, you know, stable for 4 years on this agent, you know, the oncologist may be inclined to not see the patient so often, not be getting scanned so often. You know, I have a patient now who's approaching, you know, 2 years on treatment, and I, you know, am, you know, previously been getting scans on her every 3 months, and she's currently NED, but I have to remind myself, you know, we can't really back off on those scans, at least in terms of checking her lungs. Or can we? We don't know. I mean, I think, you know, can we trust just relying on a patient coming in with a cough? And is that enough to say, if we're only going to get scans to follow their disease every 4 to 5 to 6 months, you know, is it enough to just do, you know, to just get scans of their chest to monitor for ILD? So I'm curious to know what your thoughts are going to be on that. If you have a patient that's really stable, do you still have to keep getting those chest CTs?
Well, in the first trial, we don't have enough information yet from Destiny Breast 04, but in the first trial, which was really a big dose expansion from an initial sort of exploratory study people call basket trials, where they saw this remarkable efficacy in HER2 positive disease and unbelievable disease control in patients who had received any number of lines of therapy for metastatic HER2 positive breast cancer. In that group where they didn't really know about the ILD, and so it showed up and there was some mortality and it was a little scary, all of the cases occurred in the first 12 months, except for one, which occurred at about 18 months. That was actually a fatal case. So it's pretty rare late after a year. So I think your scans can really drop down after a year. You know, when I think people are being treated early, I scan every about 9 to 12 weeks because I get nervous. I think we want to catch the asymptomatic inflammation in the lung that we can treat with steroids, keep patients on drug. You hold the cycle and keep patients on the drug, which is so effective. We have people who've been on this drug for, you know, I have a patient who's been on for 4 years who was on TDM1 for 12 months. So I think that, you know, it's clearly highly effective in patients with HER2 positive breast cancer. So NED, just by the way, for those listening, is no evaluable disease. So you can't see anything on scans. The cancer is in remission. And that's just so great to see this in patients. I will say the drug causes nausea and diarrhea and some hair loss, not a lot. And so it can be hard to manage the side effects. So, you know, we dose reduce and sometimes hold, and that helps. Kelly asked if the TDXD will be moving into the first line. There's already an ongoing phase 3 randomized trial with TDXD or this drug, also referred to as Enhertu, in the first line setting for HER2 positive metastatic breast cancer. And also there is the ability to look at patients who have brain metastases to try and understand the effectiveness. And there's a bunch of studies looking at this in patients who don't have HER2 positive disease, but have a little bit of HER2, so-called HER2 low, but it's not HER2 positive. So in June, you got to come to the ASCO forum, because in June, we're going to have a lot of data, I expect, that will give us a whole bunch of new options for treatment. And we'll talk about some of the other studies that are going on. And then the question is, would you switch the standard for second line treatment? How would you balance the side effects? So if you have somebody with HER2 positive breast cancer and they've gotten chemo and the antibodies, their cancer is growing, how do you decide between TDM1 and TDXD? Because TDM1 in general has less side effects. And for some people, it works for a long time. Although I have to say those data from Destiny Breast 04 were pretty striking. How do you make that decision?
Yeah, I mean, I think that's really, well, right now, insurance might be making it for us, that they may, it's not yet FDA approved for second line. And so I don't know if, I've requested authorization for it in second line and so far have not been denied. But there may be some cases where insurance companies, until it becomes FDA approved as the second line therapy, may be decided for us. But I just have a discussion with the patient, and I've actually shown people, the data. I think when this data, when this data first came out, Hope, I think you texted us the curves, like within, minutes of it. And it was so impressive. And I think I showed a patient the curve, that you texted me on my phone. And so I'll show them this. And, most patients are going to be willing to accept, the risk of a little bit more risk of toxicity when they see these dramatic differences.
The other thing is that it is interesting, people get a little nausea from TDM1, but, there are a lot of patients who get TDXD with HER2 positive breast cancer who really can have mild nausea that we can manage really well. We use a lot of this drug olanzapine at night. And, it's so interesting that some people just do fine, and dose reducing is hugely effective for managing the nausea for patients who get it. It doesn't always work, but it's pretty good. And I agree with you. I think that balance is, if you could control the disease for like 4 more years, it's hard. It's just hard to have people feel sick for that time, but hopefully they won't. So also, there was a question about whether or not you could pick up the inflammation of the lung we refer to as interstitial lung disease from a simple chest x-ray. And I have to say, boy, I have been struggling with that in patients. I have one patient who has asthma, so she's always short of breath. And, her lungs are clear, so that's helpful. But there's a lot of this central adjudication of the inflammatory disease, where if you have any symptoms, you're supposed to permanently stop the drug, which is really hard when it's working well for a patient who doesn't have quite as many treatment options. A chest x-ray can show the ground glass opacities, which is the inflammation, but a CT is the gold standard. So there's a lot of discussions about how to pick up ILD. Should you get always pulmonary function tests and see a lung doctor and things like that? And I think it really depends on the setting. We tend to evaluate it on our own unless there are problems. But picking it up early seems to make a huge difference in avoiding going into symptoms and more life-threatening issues. So I think we answered most of those questions, and I want to be sure that we get to the Emerald trial. We'll talk about immunotherapy more at our next meeting, which we won't talk about here because we did talk about it at our, I think, the last meeting we had. So one of the questions was, what is the path forward for patients who have hormone receptor positive HER2 negative metastatic disease who have progression on a CDK4/6 inhibitor? And this is a fascinating question because we know survival is improved with CDK4/6 inhibitors in metastatic disease. And I think the questions about the next steps in therapy, other than potentially adding a targeted agent like Piqray or Afinitor, remain a little bit unclear. So Michelle, I think you're going to talk about a little bit of one of those particular options that might be available in the future.
Yep. So I will go ahead and share my screen again. And so this, I will go through the data for elacestrant, which is, I'm going to start my slideshow. Give me 1 second. So this was presented, I've got to go down to the beginning. This was presented by Dr. Bardia, who's a medical oncologist from Mass General, and has been involved in the development of a number of novel agents. And so elacestrant is one of the many oral SERDs that have been in development. And this clinical trial was called the Emerald trial, and patients were randomized to this oral estrogen selective receptor degrader or the investigator's choice. And the background, as Hope mentioned, is that we are uncertain about what is the best path forward for patients once they have progressed on a CDK4/6 inhibitor, which can be partnered with either fulvestrant or an aromatase inhibitor, depending on what the patient's preference is, or whether they had developed metastatic disease on an aromatase inhibitor. So elacestrant blocks estrogen in a dose-dependent manner. And the difference, just in terms of mechanistically between a SERM, something like tamoxifen, and a SERD like fulvestrant or this drug, the elacestrant, is the way that it interacts with the estrogen receptor and actually causes the binds to the estrogen receptor and causes downregulation and changes in the estrogen receptor, slightly different and probably more potently than tamoxifen. So there was some phase 1 data of elacestrant in postmenopausal women with hormone receptor positive data, breast cancer. You can see it presented here. And on the right side, you can see that those green bars and the blue bars to the right are patients that experienced a decrease in the sum of their target lesion, so experienced a response to this agent. And so the Emerald study design enrolled patients who had progressed on 1 or 2 lines of endocrine therapy. One of the regimens in the metastatic setting had to be in combination with a CDK4/6 inhibitor. They had to have received no more than 1 line of chemotherapy for advanced disease. And they were randomized to receive this oral agent, elacestrant, or the investigator's choice, which could be either fulvestrant or an aromatase inhibitor. And the investigator's choice, of course, would have been driven by what the patient had not received yet in the metastatic setting. So, for example, if a patient had received anastrozole or letrozole and a CDK4/6 inhibitor, the investigator would have chosen to give that patient fulvestrant. The endpoints were progression-free survival, and secondary endpoints were overall survival. And they were specifically interested in looking at a stratification for patients that have this thing called an ESR mutation, which can be detected through a number of ways, either using a blood-based assay like Garden 360, or can be measured directly in the tumor. And ESR mutations are associated with resistance to aromatase inhibitors, and are evolving as an interesting area for us to look at for patients in terms of guiding our therapies. The baseline demographics of the patients, as I say, there was a mix of patients that were either all patients included, or those who had the mutant ESR mutation. And there were about 2/3 of the patients were wild type ESR, and about 1/3 had ESR mutations. As usual, majority were female. I think it's notable that about 68 to 70% had visceral metastasis. So lung, liver, brain, pleura, peritoneal. So this was a population, not just bone-only disease. There were, you can see here, it was about evenly split between the number of prior lines of endocrine therapy. Although it does look like there were slightly more patients in the ESR arm that had the ESR groups, the mutant ESR groups that had only 1 line of endocrine therapy. And so to cut to the chase, here is the data on progression-free survival. And it was split between looking at the entire patient population or the ESR mutant group. And so on the left side of the screen, we see the Kaplan-Meier curves. The progression-free survival for fulvestrant, that was the choice, the investigator's choice, was 1.94 months. And for all patients with elacestrant was 2.79 months. And on the right side of the screen, it was really slightly more impressive data that those patients with an ESR mutation, fulvestrant was 1.87 months versus elacestrant 3.78 months. So over a doubling of the progression-free survival in this group that received fulvestrant. And then when they looked at all patients, so those could be patients that received both the standard of care or, standard of care arm being an aromatase inhibitor or fulvestrant, they looked at the 12-month progression-free survival rate. And the reason I think that's important is, that when I showed the slide before about, a 2-month improvement in progression-free survival may not seem that impressive. But what we're really looking at is the percentage, what we'd like to see is the percentage of patients that are shifted to be stable at a period of time of 6 months or 12 months, sort of meaningful to the patient. And you can see here that among all patients, about 3 times or 2.5 times as many patients were stable at 12 months when they received this oral agent as compared to the standard of care, which could either be an aromatase inhibitor or fulvestrant. And those in the those patients who harbored the ESR mutation, it was 8.2% who were stable at 12 months. And again, the standard of care could be an aromatase inhibitor or fulvestrant. as compared to 27% with elacestrant. And overall survival, the analysis is quite early still, and there was no statistically significant differences because they had to show that the alpha level had to be quite low, the p-value very low to show because of the way that they do the statistics, but it was in favor of elacestrant as compared to the standard of care, both in all patients and those with an ESR mutation. The final analysis for the overall survival is expected to take place in early 2022 or late 2022 or early 2023. In terms of how the patients tolerate this drug, there does seem to be more GI symptoms or side effects. So looking at all grades, which means it could be minor, sort of annoyance of nausea, whereas grade 3 and 4 is more substantial, leading to a hospitalization. You can see what I circled here are ones that kind of stand out that as compared to the standard of care, and on the right side, you can see the rates with fulvestrant or an aromatase inhibitor. There was more nausea, there was more vomiting, and then there was also more diarrhea and decreased appetite, as well as more constipation. So there are more GI side effects with this oral SERD than with either the aromatase inhibitor or the injection form of the SERD, the fulvestrant. So the conclusion was that elacestrant was the first oral SERD that showed an improvement, a statistically significant improvement in overall progression-free survival versus standard of care. And there was a 45% reduction in the risk of progression or death, specifically in those patients that had an ESR mutation. There were higher progression-free survival rates at 6 and 12 months. And they felt that it was overall that the agent was well tolerated. And then we're hopeful that we will have the overall survival analysis within the next year. And this was the conclusion in blue made by Dr. Bhartia at the meeting, that this has the potential to become the new standard of care in this patient population. But I think, we still have quite a bit of work to do, as demonstrated by the final conclusion, is that we need to look at this agent in combination in earlier lines of therapy. So perhaps first line metastatic disease in combination with a CDK4/6 inhibitor or an mTOR inhibitor. And those studies are ongoing and planned.
That was great. I mean, I think it's really interesting. Can you put your slides back on again, just show the curve once. And then somebody had asked the question, although really need you to put the questions in the Q&A rather than in the chat box, because we can't monitor both. But the question about ESR1 mutations being checked in the early stage setting and changing therapy. This is a big clinical trial question. Absolutely no data on it, and would really, really not do this as a standard treatment right now, because I think that, you may have excellent disease control for many years, even when you have evidence of cell-free DNA. So I think you want to be very cautious. I just want to point out one thing that's kind of interesting here and something that's been coming up a lot. If you see those curves stay together very, very closely up until 2 months, right? That was when the first scan was done. So a lot of, the scan to assess response. So that a lot of the patients had progression of their cancer in those first 2 months. And then the curves separate at the first scan really quickly. So it is fascinating, and it brings up how we really assess these, really treatments and what our endpoints are, where you see a median that's really tiny. Like you look at this difference and how long the cancer was controlled, progression-free survival, it looks like, you barely can see it, right? And, but the curves separate after that beginning, so that the median may be not as helpful for us versus how people are doing over time who actually have disease that's very sensitive to endocrine therapy. It's a really sort of interesting and new idea of looking at these data really differently.
Yeah, that's why I kind of focused on trying to present the, information about the 12-month that, you really see there's a big difference in terms of what's happening, on the average, on the individual patient level, it may not look very different, but if you are that one patient that has stability, there's a, getting out at this point, there's clearly a big difference between the curves out here.
Yeah, and I think that it's an incredibly important point. Another question that somebody had was whether UCSF tests for mutations in ESR1. And just so that people know, it can be done in the tumor, it can be done in the blood with cell-free DNA. And we do test all the time for mutations in the metastatic setting after patients' cancers have grown on aromatase inhibitors and usually combination with CDK4/6 inhibitors. We do check often because it comes along with mutation screening, but the issue is that we're going to use fulvestrant anyway, so it's not all that helpful for us. We're still really trying to figure out exactly how to use that test to better treat patients. There's some fascinating data we didn't have time to talk about whether or not if you developed an ESR1 mutation, but your cancer was totally stable, whether it would be better to change to Faslodex or fulvestrant in the metastatic setting versus continuing on your standard aromatase inhibitor. And we don't actually really know the answer to that in the long, whether or not it affects your overall survival. I don't know if you have any thoughts on that. You're on mute.
Again, I was actually busy reading one of the questions about thoughts about differences in AEs with oral SERDs versus fulvestrant. So
in chat though, instead of Q&A. Anyway.
Yeah, it was in the chat. But I figured I would just throw out the response to that I do think, there's obviously a lot of, this is to address that question, just because I want to make sure that the participant gets their question answered, that there is a lot of enthusiasm about these oral SERDs and a lot of oral agents. There's these PROTAC inhibitor or PROTACs that are being estrogen receptor degraders, other agents that are being developed, but it's a challenge to develop oral agents that don't cause GI upset. There's just, you're going to always, I think, see more GI upset. We've done studies with oral taxanes and, there's GI upset and, it's the holy grail to be able to, certainly we want to give patients agents that way they don't have to get these 2 huge shots in the butt like they have to get with fulvestrant. And when people are getting that, that was fine when we were giving people fulvestrant and they were on it for 4 months and then they progressed. But when somebody's on fulvestrant and a CDK4/6 inhibitor for 2.5, 3 years, people get really sore and they get these scars and it's hard to find a spot to give them the shot. So I think that working on, the drug development so that the oral agents are less nauseating, cause less GI distress is important. So I decided to answer that question. And then Hope, so just can you say one sentence, your question about what you wanted me to answer before that, since I
don't think that we want to be getting mutation testing in early stage disease right now.
No, absolutely. Yeah, I mean, and I'm not even sure. I mean, I think that the timing of, doing, the mutational analysis, I mean, one could say that, should we get it, at the first biopsy, should we order it right away, the first biopsy of metastatic disease? And, I look at it as if a patient is, going to go on to an oral agent, like an aromatase inhibitor, if they develop their metastatic disease while they were not on hormone therapy, and there's sort of an equivalent decision about whether they want to do an oral agent plus a CDK4/6 inhibitor versus fulvestrant, maybe you could argue that you could use that information and drive you towards fulvestrant, but I'm not so sure. I mean, quality of life is important and they'll get to an agent like fulvestrant at some point anyway. So I'm curious what you think about that. Anyone?
Yeah, I mean, I agree with you. And I think that PADA-1 trial, there was a trial, we can talk about it more about that the question about whether or not if you switch therapy when you see a mutation and no progression of disease, if it's better or not. And interestingly, if you added up the time that patients were their disease was controlled with changing early versus changing later, it was almost identical. So, it's like, it's so hard to know that what we should be doing right now, and maybe treating in the early stage will help us better. So it's just hard to know.
I mean, if you can spare people, if many patients still prefer an oral agent. So I think checking for an ESR mutation and then finding out they have one is just going to make patients anxious, make me anxious, make them anxious. And it's just, I'm not sure it's absolutely the right thing to do.
Indeed, yes. And as I think the PATA trial where they did this early switch versus late, the overall survival data is going to be really critical. I agree. And, I think the important thing is that if you want to be traveling, let's say you want to, take your kids to Europe for 6 weeks, and your disease is doing really well on fulvestrant, if you're taking an oral SERD, not only might it work longer, but also you can travel. So there's a lot of benefits. I know we're a little over time, so we better let everybody go. I just wanted to ask everybody if you have just one final comment. Michael, any final comment?
Well, I mean, I think we talked a lot about our stuff, but I think all of the things that you all have been talking about, we often discuss patients with metastatic disease and whether or not they should have surgery of the primary breast cancer. Clinical trials have shown that maybe it doesn't benefit, maybe it does. But listening to all of this data and how things are improving more and more with metastatic disease, I think, we can't just take these older randomized trials for stage 4 primary surgery as the gospel. I mean, the way things are changing, I think we're going to have to be more open to doing potentially small surgeries of the primary breast cancer with metastatic disease if it almost goes completely away with all these newer drugs and things like that. So I think it's going to just add to the complexity of patients with metastatic disease and in terms of operating on them if they present that way, obviously. So which I think is great, because we've always been very forward thinking and proponents of surgery for metastatic patients, as long as we don't feel we're doing them any harm and that their quality of life will still be good. So it's really great that these things are making such huge changes in the metastatic population to offer them these surgeries as well.
Yeah, it is great. Great, well said. Laura, any final comments?
I think so many of these new agents are really exciting, and I think the question will be how to sequence them, how to take into account the individual patient and the side effect profiles. And I think some of these agents in the metastatic setting, which one should we move to the early stage setting to hopefully prevent the eventual recurrence of metastatic disease? So there's just a lot of really exciting drugs and a lot to figure out in terms of how to make them as effective as possible for each individual patient, which is really exciting.
Michelle and Kim.
I think everybody said it all.
Kim.
Yeah, thanks for including me. This was great.
Yeah, I mean, it's so, we work with such amazing people at UCSF. It's such an incredibly and dedicated group of people. So I so appreciate everybody for being on and taking your evening to do this. It's wonderful. And I appreciate all of the participants and your excellent questions, and really look forward to seeing you all in March. And thanks again to Melody for organizing this and doing such a great job. And it's an exciting time, and we hope to keep making improvements. So thanks.
Bye.
Thanks, everybody.